Order, order. Pat McFadden to move the motion.
Thank you, Ms Miller, and thank you for your chairing of our proceedings today. I'm very pleased to be able to open this debate. I chair the APPG for Sickle Cell and Thalassaemia, and we work for better understanding of sickle cell and better treatment for those living with this condition. I'm enormously grateful to all the honourable members who've supported the APPG's work, including our late colleague Sir David Amis, who was one of our officers. And I'm grateful to the Sickle Cell Society, who provide the secretariat function for the APPG. I'd also like to thank Parliament's Digital Engagement Unit and the hundreds of individuals from around the country who have emailed me in advance of today's debate. The focus of our debate today is the recent report published by the APPG entitled "No One is Listening," which makes a number of findings and recommendations in relation to the care of people with sickle cell. And the trigger for our report was the tragic and avoidable death of Evan Nathan Smith in North Middlesex Hospital in 2019. The coroner's report into Evan's death, published in April of this year, found that Evan would not have died if medical staff had recognised his symptoms and treated him sooner. The coroner's report pointed to, and I quote, "a lack of understanding of sickle cell disease in the medical and nursing staff looking after Mr. Smith, and a failure to appreciate the significance of those symptoms by those looking after Mr. Smith at the time." Evan Smith was just 21 years old. He had his whole life in front of him, and his death is not the only one where a lack of understanding of sickle cell and mistakes in treatment have been contributory causes. I'm happy to give way.
Congratulate him and the member for Edmonton and all the other members who have done a lot on this topic in the House. And could I also just emphasise how, despite this being a very long-running disease, we really have not paid enough attention to it at a sort of institutional level, be that at primary or secondary health care. And that's something which I think really does need urgent redress.
I quite agree with my honourable friend, and our report goes into many recommendations that could improve care. Indeed, it is a call to action. It's a call to arms following Evan's death and the deaths of others and the many near misses involving sickle cell patients. We wanted, in this report, to set out the changes needed to stop this story from repeating itself over and over again. Sickle cell affects about 15,000 people in the UK, with many more carrying the trait. Patients with the condition experience periodic crises, bouts of intense, severe pain, which sometimes require hospitalisation. These crises are treated with strong pain relief, sometimes blood transfusions, and over time they can result in organ damage, increased risk of stroke, other associated conditions, and even early death. It is therefore common among sickle cell patients to have to go to hospital regularly, to present at A&E and to be admitted onto wards. And this is an important point. For sickle cell patients, contact with the healthcare system and admission to hospital is not a one-off. It's a lifelong part of living with this condition. To prepare our report, we took evidence in 3 oral evidence sessions in June of this year. We heard from patients, from clinicians, from policymakers. We heard from Evan Smith's parents, Betty and Charles, who spoke with so much dignity about the loss of their son and about their determination to make sure that other families didn't have to go through what they have. We received over 100 written submissions, and taken together, this is the most comprehensive report on sickle cell care that the APPG has ever produced. happy to give way, yes.
Thank you. Can I just congratulate my honourable friend for his leadership and commitment to this issue, and his report that the APPG group has produced has really shone a light on some of the challenges faced by those people living with sickle cell, whether it's around some of the negative attitudes or a lack of awareness and understanding, but most importantly, patient care. So does my honourable friend agree with me that in order to tackle this issue, but also some of the multiple health inequalities that exist, will require significant investment and resource by the government, but also an acknowledgement of the structural racism that also exists within the health setting?
My honourable friend makes some very strong points, and I'm going to come on to discuss some of those, including the question of race, as I continue. Since the report's publication, I've continued to receive emails from sickle cell patients all around the country which confirm the report's findings. And I want to put on record my gratitude to each and every person who's taken the trouble to write to me, whether just after the report was published or in advance of today's debate. Now, let me set out the main findings of the report for the House, Ms Miller. Let's begin with a positive. We found a good level of trust among sickle cell patients in the specialist haematology departments in hospitals that look after them on a long-term basis. We found clinicians passionately committed to better treatment and honest enough to tell us when that good treatment wasn't there. We found that where there's a good level of understanding and knowledge, sickle cell patients are generally well treated and well looked after. But we also found a huge gulf between that good level of confidence and trust in the specialist parts of the system and treatment in the more generalist parts of the system, specifically A&E and general wards. Now, our key findings include unacceptable variability of treatment depending on where you live or who happens to be on duty at the time. Patients having to battle for the pain relief to which they are entitled. Protocols on pain relief. For example, that it be administered within 30 minutes of arrival, regularly and repeatedly ignored or not implemented. Witnesses told us of waiting for hours in excruciating pain. Some clinicians spoke of adherence to the pain relief guidelines within their own hospital as being as low as just 20 or 30%. A lack of compliance with care plans which had been agreed for individual patients, including sometimes agreed with the very hospital where the patient had turned up, being ignored, or people being told that doesn't apply here. A dangerous lack of communication between the general and the specialist parts of the system. For example, in Evan Smith's case, he'd been in the hospital for over 2 days before the haematology unit even knew he'd been admitted. This was a finding described as shocking by one haematologist who gave evidence to our committee. Delays like this can contribute to mistakes with the most terrible consequences. And as well as deaths, as I've said, we heard about a number of near misses where care had gone badly wrong, but the patient had still survived. A lack of awareness of the condition and a lack of understanding of how to respond to a sickle cell crisis among some NHS staff. Everyone in the healthcare system knows the key symptoms of a heart attack or a stroke and how to respond to those. But with sickle cell, the patient experience is often to be caught in a perpetual loop of trying to teach staff about what's happening and what treatment the person needs, often at the time the patient is experiencing excruciating pain.
Thank you, for giving way a second. I was very generous. Would he agree with me that this lack of awareness goes all the way through to the research community, where sickle cell is one of the most under-researched illnesses, despite the fact that it has so many different interesting applications around its links in with malaria, its links in with all sorts of other diseases, and that there just simply is not enough research funding which goes into understanding this disease?
I very much agree with honourable friend's point, and indeed the next finding I was going to cite was a lack of research and innovation in treatment. There's only been one new drug approved in the UK for sickle cell treatment in decades. And that was approved just before our report was published. Now, for each of these findings, we made recommendations in training, compliance with clinical guidelines, reviews of sickle cell treatment in secondary care, communications change, very importantly, a stronger voice for patients in all of this, and in many other areas. And underlying all these individual recommendations and findings, there are some key overarching themes. First of all, these experiences have contributed to a damaging loss of trust among sickle cell patients in the system that's there to help them. Some patients told us they avoided going to hospital at all costs, no matter how serious their crisis, because they found the whole experience so exhausting and debilitating, or as one woman put it, to avoid the mental strain of another battle when she doesn't have the energy to advocate for herself. It cannot be right that people who need help have so little trust that they don't seek that help from the very system of care that's supposed to be there for them. Secondly, there is the unavoidable question of race. Sickle cell is a condition that predominantly, but not exclusively, affects black people. Many patients told us of being treated with suspicion when seeking treatment, of being regarded as troublesome by staff, of being thought of as drug seekers, and of encountering negative and sometimes even hostile attitudes. The principle of racial equality in healthcare is fundamental. No one is seeking to put one group of people above another, but we do want to see equality in healthcare treatment. And right now, with sickle cell, we do not have that. This is completely unacceptable, and following this report, it must be addressed. Thirdly, these findings that we cite in our report are not new. These things have been happening for a long, long time. They've been raised time and time again. And the fact that this is still happening has led to a great deal of anger and frustration among those living with sickle cell and their families. And yet, even though all of this is the case, this might, just might, be a moment of opportunity. Now, why do I say that? Soon after he was appointed, the Secretary of State for Health spoke about the disease of disparity and how the COVID pandemic had exposed a number of long-standing health inequalities, including racial ones. And I very much welcome the Secretary of State's commitment to address these inequalities and his warm welcome of our report on the day it was published. So perhaps this is a moment when we're more aware of health inequalities than we would have been before the pandemic. Maybe this can be a turning point for change. There's no need for this to be a partisan issue. No one is pretending that the findings in our report only began in recent years or under one government. These things have been there for a long time. But perhaps the experience of the pandemic can give us a newfound resolve. Maybe it can mean that this time people do listen. From the Secretary of State and the Department to the NHS in every part of the United Kingdom, we want this report to mark a moment of change in the treatment of sickle cell, to ensure that the issues raised in this report are addressed once and for all, to ensure the training is improved so that staff throughout the system understand and have a knowledge of the condition, to ensure care plans and pain relief protocols are adhered to by both the generalist and the specialist parts of the system, to step up research and innovation in treatment, to restore trust among sickle cell patients, and most of all, to ensure there is equal health treatment for everyone, regardless of the colour of their skin. That is not too much to ask for, but we do not have it at present. So today I appeal to the Minister and the Secretary of State, and indeed my own front bench and the other parties present, to become our allies in this and to work with us. Please don't let this be a lost opportunity. Let us today collectively resolve that we will not have me or another chair of the APPG standing here in a few years' time making exactly the same points that I'm making today. let's make sure that this time people do listen, that we act on these long-standing failures in the care of people with sickle cell, and that we improve healthcare for people with this condition once and for all. Thank you.
The question is that this House has considered the treatment of sickle cell. Can I just remind members, if they want to speak in the debate, they could rise in the normal way to indicate that. I intend to call the front bench, the Minister and the spokespeople around just over 30 minutes before the end of the debate, whenever that falls. And again, I'll clarify that if there's a vote. And if perhaps I won't put in a time limit, we'll see how we go. If everybody could be respectful of each other's time, we should be able to get everybody in. I call Dr. Greg Clark.
Thank you very much indeed, Mrs Miller. It's a pleasure to serve under your chairmanship. Can I congratulate the right honourable gentleman on securing this debate and for his very powerful speech and indeed his leadership of the APPG. I agree with every word that he's said, and he's right that this is something that should unite all sides of the House. I have the honour to have recently replaced our very good friend, Sir David Amos, as the Conservative officer of the APPG. It is a great responsibility. I do so with pride and look to continue the formidable work that Sir David did for this very important cause, as for so many other causes in this House. The right honourable gentleman has given a comprehensive account of a very powerful and impactful report. And so I just want to highlight a number of its observations and recommendations, drawn as they were from the evidence from people who are living with and, in many cases, have suffered the consequences of family members falling victim to this condition. And the first is this, to reflect the point of inequality that the right honourable gentleman referred to. I have the honour of chairing the Science and Technology Committee, and some members will have read the joint inquiry report that my committee and the Health and Social Care Committee conducted. And one of the chapters of that was the differential impact of COVID on different groups in society. And we made some recommendations as to how we can improve our practice in the future. As the right honourable gentleman said, this applies very much to sickle cell. And in particular, I think what the report emphasises is the need for if I could put it this way, a geographical strategy for the management and response to sickle cell. As the right honourable gentleman said, sickle cell affects disproportionately black people, and we know that the distribution of people of ethnic minorities is not constant, not consistent across the country. And that will mean that there are some places that have a ethnically diverse population who are well used to coping and helping people with sickle cell, others not. But that can't be left to be a matter of chance, because all places have people who will have sickle cell. And so it's very important that we put in place connections between those hospitals and those trusts with deep experience and those that don't, so that they can be accessed immediately when the circumstances arise. And that is a very important commitment that we should make. The opportunity with the establishment of 42 integrated care systems across the NHS is the ideal mechanism for that. The second point I wanted to emphasise in the report, which again the right honourable gentleman touched on, is the differential practice within hospitals. Some disciplines, such as haematology departments, are used to and have very high levels of understanding and indeed expertise in caring for sickle cell patients. But other departments and disciplines within the same hospitals do not, and particularly concerning was the patchy experience of A&E departments, of emergency medicine in this. So it's very important that, and I hope the Minister in her response will point to ways in which the diffusion of knowledge across hospitals, rather than it remaining in silos, is something that can be seized on as a practical outcome of this report. It's something that is clearly attainable. The third thing I wanted to emphasise is the importance of timely pain relief given to people presenting in A&E who have sickle cell. We know that there is an acute need for that pain relief to be administered promptly. The NICE standard is that should be within 30 minutes. But the report was very striking in noting that only 30% of adults, for example, said that they were given pain relief early enough. That is a great concern, that people are suffering great distress during that time with consequences, longer-term consequences for their health. And it concerns me at a time of COVID and entering into the winter, when we know in all of our experiences, constituency MPs, that A&E departments are under particular pressure, that waiting times are longer in A&E departments for reasons that we understand. There is an especial need for emergency medical practitioners to be able to not just spot, but to know how to respond to the very immediate needs of people presenting in A&E departments with sickle cell. And the fourth aspect I would like to emphasise, again, I draw from the work that we did in our COVID inquiry. One of the consequences of COVID and the response to it in hospitals was that, as we know, there are great restrictions on relatives and carers accompanying people into hospitals. We looked in particular at the experience of people with learning disabilities who didn't have people to advocate for them. Now, obviously, in talking about sickle cell, we're not talking about people with learning disabilities, but nevertheless, the assistance that people who are their relatives, loved ones and carers, who, especially at a time of intense pain, are able to communicate the particular needs of the patient at a time when the sufferer may not be able to express themselves dealing with the pain that they are, is particularly important. And I hope that during the remaining period of this COVID pandemic, this might be recognised, that there are patients that need people to help communicate what their needs are if they're in a state that they can't do it directly themselves. And of course, one means of doing this is through attention being given, being paid to their care plan so that they should be followed. That would be a way in which we can make sure that the right treatment is given. They are just four of the themes that come out of a very comprehensive and I think powerful report. But there are four aspects that I think have a particular relevance to the immediate weeks and months ahead as we face some difficulties across the NHS. It's very important that as we seek to ensure that COVID doesn't exacerbate inequalities, this potential further source of inequality is attended to and action is taken by the NHS so that the conditions during the weeks ahead can be better than would otherwise take place.
Kate Ossamore.
Thank you, Ms Miller, for calling me. It's a pleasure to serve under your chairmanship. Chairship, I think is a better word. I also want to thank my right honourable friend, the member for Wolverhampton South East, for securing this important debate and for setting out a very strong argument. First of all, our thoughts must be with Evan Smith, who tragically died at North Middlesex Hospital in my constituency, with a determination to prevent further tragically avoidable deaths. The All-Party Group for Sickle Cell and Thalassaemia must be given huge credit for putting together the hugely important No One Is Listening report on the failures of sickle cell care and producing an extensive and thought-out list of recommendations. What has clearly been found is that while the details of Evan's case are particularly distressing, this is not just an individual failing of one hospital, but reflects widespread shortcomings in care and a lack of institutional knowledge which has led those with sickle cell to be fearful of receiving secondary care and attending hospitals. Indeed, North Middlesex Hospital itself is situated in an area with a large black population, and compared to the average hospital, should have been well adept at caring for sickle cell patients. Evidence of the dismissal of the pain of sickle cell patients sadly tally with what has been highlighted by other studies into the disparities in treatment of black people by healthcare staff, such as by 5 Times More and their work on black maternal health. I wholeheartedly endorse the recommendations proposed by the All-Party Group's report. I want to highlight a number of those recommendations. First, the North London Integrated Care System, which my constituency falls under and the North Middlesex Hospital falls under, should develop a concrete plan to improve sickle cell care and share lessons learnt across the entire country. North Middlesex Hospital should also engage with the parents of Evan Smith, Betty and Charles, regarding an appropriate memorial for their son. I would also urge the government to tackle the report's recommendations with the seriousness that it deserves. Knowledge of sickle cell amongst healthcare professionals must be improved by mandating that universities should provide training in sickle cell as part of the curriculum. And Healthcare England should develop a mandatory e-learning module for staff treating sickle cell patients in high prevalence areas. The standard of care must be improved by developing individualised care plans for sickle cell patients with copies passed on to the patient and all of their carers. And NHS Trust should develop action plans to ensure compliance with the clinical guidelines to deliver pain relief to sickle cell patients within half an hour. Finally, the NHS Race and Health Observatory should undertake a study of sickle cell care, examining how racism affects the experiences of patients and examining the level of prioritisation sickle cell patients are given compared to other conditions. While sickle cell patients advisory groups are flourishing, they should be set up and be given the resources that they need to have an oversight on sickle cell services across all hospitals. There is a lot of work to be done, but the way forward has been set. I also want to add at this point that North Middlesex Hospital has a unit for people who have sickle cell. So what happened to Evan should not have happened. The A&E experience for all patients that have sickle cell needs to be looked at with urgency. I thank you for listening.
Jim Shannon.
Thank you, Madam Chair. And first of all, can I thank you for giving me the opportunity to speak in this issue. I'm the party's health spokesperson, and it's always a pleasure to speak in any health issues. I was just talking to my colleague and friend to the right-hand side there, trying to remember the member for Stephen Powner, member for Ealing, introduced me and told me about this disease when he was the MP. He and I had a good friendly relationship, but I went to the APPG and sickle cell thing that was happening, through his introduction, I perhaps gained a small bit of knowledge in relation to it. But I want to come here today to speak on behalf of those people who have sickle cell disease. We don't have it in Northern Ireland. Thank the Lord we don't have it in Northern Ireland.
Order.
Just getting started.
In the House. We have a division in the House of
I'll
Commons.
do it all again.
I'm going to suspend the sitting for 15 minutes and 10 minutes for each subsequent vote. But could I encourage members to return to this chamber as soon as possible so we can resume the debate as soon as possible and ensure as many people as possible are able to participate. Thank you. Sitting order. Apologies to colleagues for the delay. If the next break is 15 minutes, just one break, then we should complete this debate after that at around 5 o'clock or just after 5 o'clock, if people could bear that in mind. And I call Jim Shannon.
Thank you, Madam Chair. I'll not repeat what I've already said. We'll let it go at that, and I'll not take any more in about 4 or 5 minutes, and I'll give other people a chance maybe to see what we can get over time. I was referring to the former Honourable Member for Ealing, Stephen Pound, and my introduction to sickle cell and understanding that process. It also happened about a time that one of my staff members, her daughter had taken ill, and she lives over here. Not because I'm smarter than anybody else, as I'm not, when it comes to health issues, but I just wondered, and I happened to say to the lady, I says, I hope she hasn't got that sickle cell. Well, she couldn't have it, by the way, I understand, but what she did have was primary biliary cholangitis. It's a lifetime health issue, which will be a forever illness, so it is. But it was just because at that time I'd been made aware of sickle cell and wondered, was there any connection? But sickle cell can affect anyone, though it is more common in people from the African and Caribbean backgrounds. The NICE estimates that there are currently some 12,500 to 15,000 people with sickle cell disease in England, while data from NHS Digital shows that there were almost 25,000 hospital admissions in England in 2021 where the primary diagnosis was sickle cell disorders. So there is a significant issue in relation to sickle cell, and it's very clear, and I commend the Honourable Gentleman for introducing the debate. I should have done that at the beginning. Apologies for not doing so, and raising the awareness, and all the other speakers here today. I support them and want to put that on record as well. A stem cell or a bone marrow transplant is currently the only cure for sickle cell disease. Neither are commonly undertaken in sickle cell patients. The US National Heart, Lung and Blood Institute note that a well-matched donor is needed for a patient to have the best chance for a successful transplant. I know that in my introduction with the former Honourable Member for Ealing, that was one of the things that we looked at in relation to transplant issues. But most patients who have sickle cell disease are either too old for transplant, since the risks associated with a transplant become greater as a person gets older. It's about the opportunities for that there. So the older you get, the less you may even want to get it, the donor or the transplant, or do not have a relative who is a good enough genetic match to be a donor. There are many issues which need to be resolved, and from reading the APPG on sickle cell and thalassaemia, no one's listening into the quality of care received by sickle cell patients. My heart went out to those people who quite simply feel abandoned, and many of them do. And as how we improve that, I see the Minister in her place, and the Minister and I are good friends, and I know that when it comes to asking the Minister for help for this issue, that she'll come back with a response that hopefully the proposer of the debate and others who are questioning will be happy with. The key findings of the report are a true indictment of the current state of play for sickle cell sufferers. To see that there is evidence of substandard care for sickle cell patients admitted to general wards or attending accident and emergency departments, including a widespread lack of adherence to national care standards, is, I believe, unacceptable. As is the fact that there is a clear low awareness of sickle cell amongst healthcare professionals, and examples of inadequate training and insufficient investment in sickle cell care. So when the Minister comes back, perhaps we could have some indication of how we can improve that, to raise the awareness and address the sickness levels which are clearly and many of the sickle cell sufferers feel that they are not being answered to, and it's not a criticism of government, but it's just that if we indicate, and we are doing that through this debate, that there's a problem and there's a way of curing it, let's do that. There's a clear breakdown here that must be addressed, not simply clinically with treatments being made widely available, but further with the training of medical staff and teams to understand this disease and the other medical contradictions of the disease. So that's the issue, Minister, we're looking for a response on. I conclude with this comment, Madam Chair. I support the Honourable Member for Wolverhampton South East in his attempt to highlight this plight, as he's done so well today, and other speakers as well, and others to follow will do it equally well. Not simply to highlight the problem, but to push government and the Minister for action to begin the steps to rectify their approach that we are currently taking. Madam Chair, thank you so much.
Lawrence Eshalomi.
Thank you, Ms Millen. It's a pleasure to serve under your chairship. And I also pay tribute to my friend, the Honourable Member for Wolverhampton South East, for securing this really important debate and his tireless work as the chair of the APPG on sickle cell and thalassaemia. And I'd also like to reflect on the work of the late member for South and West on sickle cell as a former officer, and say how poorer we are today without his contributions, which I know would have been very timely and well received by all of us. Madam Chair, this debate is quite personal for me, and reading through the report on Evan's lack of care and failings brought back many memories. My late mother suffered from sickle cell anemia. Sickle cell anemia is a disease that doesn't discriminate. My late mum, was one of 12 children. Same mum, same dad. She was the only child that had full-blown sickle cell. Some of my aunts and uncles have the trait. I found out that I had the trait when I got pregnant with my daughter, who's now 6 years old. I went on to have a healthy daughter, and I went on to have a healthy son. My daughter has the trait, my son doesn't. That shows how sickle cell can affect anybody. And reading through some of the failings in Evan's care and lack of care, I remember, as my late mother's principal carer, some of the issues that we encountered. And this was in the 1990s. As a young child, I had to learn about diamorphine, cocodamol, penicillin, folic acid, and the many variety of painkillers that sickle cell patients had to take. I knew how important it was for my mum to have access to oxygen when she had shortage of breath. And to hear that Evan had to call 999 from his hospital bed to get oxygen in 2019 breaks my heart, to see sickle cell patients being failed badly. My mum had 2 oxygen units at home. That's how severe her sickle cell was. I know for many sickle cell patients, this time of the year is so difficult, making sure they're wrapped up warm, because once they start getting cold, that pain gets into their bones. And the many nights I would have spent rubbing my mum's legs, her back, trying to help her relieve the pain. I know how important it is to make sure that when the ambulance arrives, you outline the symptoms to them, so that when she arrives at A&E, they prescribe her with the right drugs, not paracetamol. I know how to describe the searing pain that sickle patients face when they are going through a crisis, and with doctors and some nurses looking at them with a blank expression because they don't understand. That pain that my mum used to describe to me, someone's chiseling at your knee, your bones, the pain within your joints, and why you need that strong pain medication, not that you are addicted to painkillers. Calling sickle patients addicts is totally wrong. And I know how important it is to make sure that access to good quality housing, making sure that those patients who suffer from sickle cell have time off for their appointments. I know how timely it was between a matter of life and death if my mum didn't get the blood transfusions. And to think that this 21-year-old boy was failed. With the right level of care and support, sickle patients can lead a fulfilled life. My mum went on to have 3 healthy children. I'm one of 3 girls. And thankfully, my mum saw my granddaughter before she died. My mum died in 2015 when she was 60. Evan will never have that chance. He won't have a chance to start a family. His parents won't have a chance to see their grandchildren. He won't have a chance to fulfill his life ambition. Why? Because he was failed. He was failed by the same doctors and nurses who should have helped him. The same doctors and nurses who in that area have a high prevalence of sickle cell patients. So why didn't they know what to do?
That's right.
The same doctors and nurses who should be caring for sickle cell patients, regardless of your race. Now, this report highlights the many failings, and I won't go into it as many members have highlighted. But it is important that we do listen to those clear recommendations. The fact that we are seeing our community, not just in London, but right across the UK, become more diverse. We have to make sure people going into the health system now understand this disease. We are going to see more diverse communities, and it's not just about BME people in London. It's about BME people right across the country. Our population across the country will continue to be diverse, which is something we should celebrate. But those people will be scared, not wanting to move and live in areas where there isn't that understanding. We had the understanding at King's College Hospital where my mum was cared for, and St Thomas's in my constituency now. And there were times when my mum would be scared to visit family members in other parts of the country because she knew that if she came into a crisis, would they understand her if she had to go into hospital? We shouldn't have that where sickle cell patients are scared to travel and leave. Basic things that should be denied to everybody, that should be available to everybody, is being denied to sickle patients. I thought those days of patients not being believed for their pain threshold, patients being told that they should come back, patients being told that they should go and buy paracetamol over the counter. All of that seems to be happening now. So it's really important, and I hope that the Minister will respond in those critical recommendations in this report and come back with a clear action plan. No one should be failed how Evan has been failed. No one should have to die because they suffer from sickle cell.
Janet Dolby.
Thank you, Madam Chair. And there's been some really powerful contributions, and especially from my honourable friend from member for Vauxhall. And I just appreciate everything that has been shared, and the obviously the turmoil and the difficulty that has been endured when she had to care for her mother. And I just want to acknowledge that and show her my appreciation and for thanking her for her contribution. Madam Chair, I can also congratulate my right honourable friend for Wolverhampton South East on securing this really important debate. He knows only too well of the need to speak about the experience of children, young people and adults who have sickle cell disease and where they experience health inequalities. People with sickle cell disease desperately need us to raise their profile in this place, and I'm so pleased that we are able to do that this afternoon. My honourable friend and I have worked hard on this together on the APPG for sickle cell and thalassaemia. And it is truly shameful that the history of treatment of sickle cell in this country is a story of ignorance and neglect. This disease causes unimaginable suffering, and most often to people from African and Caribbean descent, and a people group who already experience medical discrimination. I've spoken out frequently about health inequalities in this place, with specific reference to the impact of sickle cell in diverse communities and the correspondingly poor investment into care and research. I've heard first-hand stories of the suffering of patients' physical pain and psychological trauma, from not being able to afford their medication, their condition not being understood as a student, people not being understood in the workplace and indeed in hospitals. People feeling worried about disclosing about their illness and their voices not being heard and their pain not being believed. A young man has told me he is afraid to attend an A&E department in case he is not believed and treated correctly when he is in a crisis. This is not the first time that I've heard this, that going into hospital should be about alleviating fears and worries. It's a place of safety, and it is not the general experience from some people suffering from sickle cell. When a doctor and nurse does know how to treat someone with sickle cell, that patient feels confident. But too often this is not the case. Our nation has already heard about the case of Evan Nathan Smith.
Order. The sitting is suspended for 15 minutes. This is a third reading, so there can only be one vote. So let's reconvene in 15 minutes quicker if people are able to. Thank you very much. We're all back. Thank you very much for that. So I'll recommence the debate, and just to confirm, so that everybody can plan their days, we will end the debate at 4:56, and I will call the front bench at 4:24, and I call Janet Dolby to continue her remarks.
Madam Chair. Our nation should know, already heard of the case of Evan Nathan Smith, but there were also 2 deaths of 2 army recruits during military training. In fact, if they had been treated appropriately, all of them, their deaths could have been avoided. One of the young men was aged 21 years old, and the other one was 31 years old. The death of the army recruits was undiagnosed with sickle cell. However, a coroner has warned, or had warned, that these deaths could be repeated without urgent government intervention. In the recent inquiry by the APPG, found that the majority of sickle cell patients surveyed had received inadequate healthcare support, adding to their physical discomfort and distress. Our NHS is underfunded, but they need the resources to train staff and to have a specialist understanding of sickle cell. The government has decided not to fund the research that is so desperately needed. And the government needs to say, why is this, when the research is so desperately needed? Will the Minister today give young and old people that are suffering from sickle cell hope for their future by ensuring that training for sickle cell is included in the teaching of medical people, nurses, midwives, and that this is included in their degrees at university and colleges? A further area that needs addressing most urgently is how to respond to a sickle cell crisis. This information is needed. These professionals need to know what to do. This is when sufferers experience a severe attack where their blood cells stick together. It causes unimaginable pain across their whole body. Sadly, too often medical professionals do not recognise the signs of a crisis. Stigma and stereotyping can have a part to play in this, and racial discrimination must come to an end. The necessary pain relief is not given, and if the pain is not given, the conditions can worsen and go on to affect internal organs, which in turn then causes other medical issues, and at its worst leads to death. But this can be prevented if the government has the will to make the necessary changes. NICE guidelines state that the first dose of pain relief should be administered no longer than 30 minutes after a sickle cell crisis starts. So can the Minister tell me why this target is so often missed? And why does the Care Quality Commission not recommend that this is an official guideline? And what do they intend to do to address this? The APPG report made several recommendations, including guidance for specific NHS trusts to improve their performance, and requested commitments to raise awareness of sickle cell in the medical community, from paramedics to A&E doctors to senior consultants. Professionals from across the public sector also need educating in what sickle cell involves, from nursery nurses, teachers and employers. Children, young people and adults with sickle cell need to be understood. We should also investigate whether we can test every baby for this disease. Currently, we know that around 300 babies are born with sickle cell each year. And I ask that the Minister and their team urgently read the APPG report, if they have not done so already, supported by research from the Sickle Cell Society, and take heed of the guidance to change practices. Because at the moment, sickle cell patients like Shabi Osaba are describing sickle cell care as a lottery. On some days, in some hospitals, sufferers get the help they need. In other days, they don't. And that's just not good enough. Madam Chair, over 2 years ago, I asked the then Health Secretary if he would remove the current charge for prescriptions for sickle cell medicines. Some patients are on 5 different medications a day for a long life illness. This is a heavy financial cost. The Right Honourable Member for West Suffolk promised to look into this, but all this time later, nothing has changed. Will the Minister take forward this measure and relieve patients of yet another burden on their lives? I will also bring it to the Minister's attention that it is more cost-effective to the public purse to prevent hospitalisation by adding this long-life disease to the list for free medication, compared to the cost of treating people with this disease in hospital. I'm sure honourable members would agree that prevention is better than cure. In this case, preventing a crisis by free medicine is much cheaper than being in hospital. And I impress upon the Minister to have a conversation with the Chancellor concerning this. There is so much more that needs to be done. And on behalf of those people with sickle cell and their families, I ask the Minister to respond appropriately to the serious concerns that has been raised by me and by other members across this chamber. Thank you.
Belle Ribeiro Addy, and can I just remind you that we need to go to front bench speeches at 4:24. Thank you.
Thank you very much, Mrs. Millen. It's a pleasure to serve under your chairship. I want to start by congratulating my friend, the Honourable Member for Wolverhampton South East, for securing this debate and for his sterling work as the chair of the APPG on Sickle Cell and Thalassaemia. And also commend my friend and neighbour, the Honourable Member for Vauxhall. She always speaks with such affection about her mother, and I hope she knows that her mum would be so incredibly proud of her if she was alive today. Now, the landmark report from the APPG, which was triggered by the tragic and unavoidable death of Evan Nathan Smith in North Middlesex Hospital, reveals the terrible truth of sickle cell treatment, the substandard care, the stigmatisation and the lack of prioritisation of this condition. So I was pleased myself as an officer of the group that the report came forward, but also to be able to give evidence as somebody who cared for somebody with sickle cell, someone who lost a loved one, my friend Adjua, to negligent care. I sat with her in many hospital admissions, and I witnessed mistakes, I witnessed mistreatment. And, you know, she said to me on more than one occasion, one day this hospital is going to kill me, and one day they actually did. So I hope that the Minister has read this report and taken into account the many recommendations and will hopefully outline today what the steps the government will be taking to improve the treatment of sickle cell as a condition and the experience of sickle cell patients within our National Health Service overall. I also hope that the Minister will touch on what steps the government will be taking to specifically improve the treatment of black sickle cell patients, because unfortunately for those of African and Caribbean heritage, the experience of sickle cell is made far worse due to the prevalence of institutional racism. Now, we've heard in several past debates and through various inquiries, reports and personal accounts how racist attitudes can negatively impact a patient's healthcare and experience, from a lack of research, certainly on sickle cell, that's a major issue, biased perceptions of pain tolerance, drug habits and medical knowledge, as well as experiences of overt racism, all of which come together to make the experience of living with any condition difficult, but living with sickle cell even harder. And I would just like to say, whenever we talk about institutional racism in the NHS, sometimes we are met from members opposite saying, you know, why are you calling our NHS staff racist? We're not calling NHS staff racist. We value our NHS staff. We are just recognising that the institution of the NHS, which is governed by the government, has issues when it comes to race, and that the policies and practices create biases which cause us problems. We want to know what the government is doing about it. Now, sickle cell is often referred to as an invisible illness because of the pain and how it's experienced, and often it's invisible to others. But there's also a really distinct lack of education and public awareness of the condition and the symptoms. And I point specifically to the issue of education, because I studied biomedical sciences and specialised in cellular pathology as an undergraduate degree, and I was quite struck because of the amount I knew about sickle cell before I went to university, just how much it was used as an example, but just how little those teaching me knew about the practical aspects of it. And I think if we don't improve education of those that treat people, we are never going to improve the outcomes. So that definitely needs to be looked at. Now, the recent removal of discriminatory blood donation restrictions on black donors was really a massive step in the right direction, and I really welcome this announcement. The largest beneficiaries of this change will be those patients who are often treated through blood transfusions and need rare blood subgroups, such as RO, that are more common in black people. I have this blood group, and so I give blood, and I ask for all people from the black community, and actually all communities. Blood donations have gone down so rapidly during the pandemic. They're needed no less at the moment, and I encourage everybody to give blood. And I would love to see a blood donation stand in Parliament one day. There's so many of us here, and we should all be able to roll up our sleeves and give a pint or two. Yes, I will do.
Shannon.
I think the government has been very keen to have blood donations, and the Honourable Lady has very kindly volunteered and says she's been doing it. I think she should be perhaps a poster lady for the campaign, and maybe the Minister would take that on board.
I thank the Honourable Member for his contribution and look forward to seeing him roll up his sleeve as well. Now, maintaining those discriminatory blood donation rules for so long was really poor because it was based on outdated HIV science, and it denied thousands of black sickle cell patients the treatment that they needed. And not only that, the legacy of these rules resulted in a reluctance amongst the black community to come forward and donate blood, and these restrictions have resulted in a shortage of black blood donors and have a severe effect on the willingness of the black community to donate overall. So we have to work to undo that damage. And I'm calling on the Minister today to make a promise to all of us here and those who are keenly watching this debate to ensure that the government will act to improve the quality of care and treatment of sickle cell patients. Words are good, but action is better. And my honourable friend touched on the issue of prescriptions and just how much of a barrier that is to receiving proper care. We want to see actions such as that. Those watching at home are doing so in eager anticipation of something that will give them hope of better treatment, and I sincerely hope that the Minister won't let them down today. Thank you.
Martin Day.
Thank you, Mrs Miller. Grateful to the Honourable Member for Wolverhampton South East for securing today's important debate and for the manner in which he opened it, and also for the work which has been conducted through the APG which he chairs. He said we should all be concerned by the lack of understanding which exists regarding sickle cell disease, and I think we can all agree with that fact today. It's been a very consensual debate. A valuable reminder that this issue is about pain and loss that can impact many families. Pain which was well demonstrated by the personal testimony of the Honourable Member for Vauxhall, who spoke so movingly of her mother's experience. And I'm in full agreement that the increasing diversity of our communities amplifies the needs for greater awareness of this disease. The Honourable Member for Lewisham East used the term ignorance and neglect, which I think sums things up pretty well, given that the deaths from sickle cell disease are pretty much avoidable. And the Honourable Member also highlighted the cost of sickle cell medicines, a point I will return to later in my own comments. The Honourable Member for Streatham also spoke of her personal accounts of experience from the disease and spoke strongly about the institutional racism which has been experienced. And I think this is a matter which should concern all of us from all parts of the country. I would like to take this opportunity to also commend her for her own action on blood donation, something I must confess I've always been too frightened to go and do myself. But I commend her for that and the importance of giving blood, which is maybe something we all need to consider more. Like the Honourable Member for Strangford, I was very impressed by the All-Party Parliamentary Group inquiry's report titled No One's Listening, which was published in November 2021 with the stakeholder group Sickle Cell Society. The report found that sickle cell patients too often receive substandard care. Community care for sickle cell patients is generally inadequate or non-existent, which leads to unnecessary admissions to hospital. And awareness of sickle cell disease among healthcare professionals is low, as we've heard repeatedly today. The Honourable Member for Tunbridge Wells highlighted the differential impact of geographic factors and even within the same hospitals, and I think that's a very important point, one I hadn't properly considered, although I had thought on the race element affecting different parts of the country differently. And the Honourable Member for Edmonton highlighted the fear of sufferers from even attending hospitals, and particularly even in areas which have a high population base susceptible to sickle cell disease. And that, again, was a point I hadn't thought of before she said, so I'm grateful for that commentary. Sickle cell disease overwhelmingly affects people from backgrounds, from particular heritage backgrounds, and the report highlighted the role of racism when diagnosing and treating sickle cell patients. People from African, Asian, Caribbean, Eastern, Mediterranean, Middle Eastern backgrounds being much more likely to have sickle cell disease or carry the gene. It's impossible, therefore, to debate this subject without considering the issue of race and the failings to adequately provide equality of treatment within the existing system. It's particularly concerning that many sufferers believe that racist attitudes affect healthcare providers' perceptions of the disease, and a number of members have highlighted the systematic racism which appears to exist. Sickle cell disease is a genetic blood disease. There are treatments to manage it. It's a lifelong condition, and these disorders are inherited, the only cure being with transplants. Approximately 5% of the world's population carries the trait gene for inherited blood disorders, and around 15,000 sufferers in the UK have sickle cell disease. It affects how your body produces red blood cells. Normal red blood cells are round. The red blood cells affected by the sickle cell disease harden and become sickle-shaped, like a crescent moon. And this causes the red blood cells to die too quickly and block blood vessels, leading to symptoms that are often painful, as we've heard from a number of the testimonies today. In Scotland, the Scottish Government is committed to improving the availability of treatment services in order for patients with sickle cell disease to receive the care they need, with the Scottish Government's NHS recovery plan for 2021 to 26 setting out the plan for healthcare over the next 5 years, including investment for more than 400 million to create a network of 10 national treatment centres across Scotland, increasing capacity for diagnostic care. The plan also sets out the Scottish Government's 155 million investment to provide general practices and their patients with support from a range of healthcare professionals in the community. And that plan includes, for example, the recruitment of further pharmacists to help with patients' repeat prescriptions and medicine reviews, community nurses to assist with the diagnostic test and chronic disease management. It is vital, I believe, that we design and develop services that meet the needs of everyone, with a focus on those that are experiencing health inequalities. And we've heard much of some of those inequalities today. I believe the UK Government should follow the lead of the Scottish Government in the provision of free prescriptions to those who suffer from sickle cell disease and beyond. Sickle cell disease usually requires lifelong treatment, and a medicine called hydrocarbamide, I can probably spell it even worse than I pronounce it, may be prescribed by a patient's doctor in order to manage episodes of pain, and patients are usually told to take it as a capsule once per day. In Scotland, we abolished prescription charges in 2011, but in England, the current charge is £9.35 per item. There is currently a live e-petition, 588355, to encourage the UK Government to add sickle cell to the prescription charge exemption list. The UK Government responded on the 6th of August that they have no plans to make changes to the list of medical conditions exempting patients from prescription charges. That petition has a few days left for people to continue to sign. So in closing, Mrs Miller, I would encourage the Minister to reconsider the position on prescription charges and to support the recommendations which were detailed in the excellent All-Party Parliamentary Group report. Thank you.
Ms Kendall.
Thank you. And it is a pleasure to serve under your chairmanship, Mrs Miller. Like everybody else, I want to congratulate the Right Honourable Member for Wolverhampton South for securing this debate on what is an extremely important issue, and I want to pay tribute to the members, officers and staff of the APPG on sickle cell and thalassaemia, because I think this report, No One's Listening, is actually one of the most powerful, serious and substantial reports that I've read in a long time in this place and working in the health and care field. And the detail it provides, the analysis and the recommendations are really important and cannot be ignored. And we know, as we've heard from so many honourable members, that the report was carried out in response to the absolutely tragic case of Evan Nathan Smith, who died in just the most utterly appalling circumstances, as honourable members have said, with his whole life ahead of him. And it is crystal clear from the coroner's inquest that he wouldn't have died if it hadn't been for the failures in his care. The failure to get him the pain relief he desperately needed, the failure to give him a timely blood transfusion, and the total, utter lack of understanding about sickle cell in the staff looking after him in an area where they should have known because of the local population. But I think the most important thing in the report is that it highlights two far more fundamental issues, which my friend, the Right Honourable Member for Wolverhampton South East, picked out in his comments today. The fundamental failings. Number one, that this is not an isolated incident. As my honourable friends, the members for Vauxhall and Streatham, so powerfully and personally described in their contributions, it is a pattern of years of substandard care in this crucial area, and patients understandably just losing trust in the system. And secondly, the issue of race and the racial inequalities in the standards of care being provided, the stereotyping and discriminatory attitudes towards black people that have contributed to this. And of course, those two things are inextricably linked.
Could I just encourage the Honourable Lady to
I do apologise.
Sorry. Voice that way, thank you.
I apologise, speaking to people rather than into a void in a way. So I think unless we understand those two fundamental issues, we're never going to get the change we need. And I want to use my time not to repeat what others have said, but to talk about how do we get real and lasting change. Thinking about some of my own experience of working in health and care for 20 to 25 years. And because I think that there's a lot in this report which is excellent. Much of it is coming from the top down, and there are important recommendations that should be followed. But in my view, the real change we need to see is to give patients and their families far more say, control and involvement in the system, because that is how I think we will get lasting change. 5 key areas I think need to be addressed. Firstly, is tackling the appalling variations in care that the report highlights. And I think the really important issue, which is something my honourable friend, the member for Vauxhall, picked up upon, is that as our country becomes more diverse, something we should celebrate, this isn't going to be an issue just affecting London. This was a point, I think, given in evidence to the APPG by Global Blood Therapeutics, who have clearly said the geography of sickle cell is starting to change, with patients increasingly moving outside of London. So in understanding that, we've got to make sure that the variations in care are ended through all parts of the country. I think one of the most important recommendations in the report is that all NHS trusts should share findings of their internal reviews into incidents involving serious sickle cell care failings with the National Haemoglobinopathy Panel, so that learnings can be communicated across the country. That is something I think that is within the Minister and the Department's remit to ensure happens. So I hope the Minister will set out what she intends to do there and what discussion she's had with NHS England about making that happen. The second key recommendation around variations is that the CQC should make compliance with the NICE clinical guidelines for the delivery of pain relief within 30 minutes for sickle cell patients an essential criteria that it uses when assessing NHS trusts. As far as I can see, the CQC has not responded to this report, and I wonder what discussions the Minister has had with the CQC about this, because that, I think, is crucial. The third issue around variations, something touched on by the Right Honourable Member for Tunbridge Wells, is that we now have integrated care systems across the country. I have got to be honest in saying that every time there is an NHS reorganisation, and there have been many of them over the last 2 decades, I've been involved in some of them myself, we lose institutional memory about these issues, about these findings. What discussions has the Minister had with colleagues in the NHS about how we ensure that those who have made changes, who are trying to make a difference, that is reflected in the new ICSs as they get up and running across the country? Second key issue, I think, is around communication and the lack of joined-up care. There are so many parts of the NHS where those conversations don't happen, and it's patients who are left telling people what they need. Will the Minister therefore set out what she will do to try and ensure that NHS trusts improve communication within their own hospitals, and the particular recommendation that all haematology teams are informed whenever a sickle cell patient comes into A&E or onto a general ward? I have in my own constituency, University Hospitals Leicester. That is something I will be pursuing with them as a result of this report to make sure that happens. Thirdly, absolutely critical, is about improving awareness of the condition and training. I think this has the power to make one of the biggest differences, because the staff aren't on purpose not understanding it. They need to be trained in it. And the report sets out recommendations about universities having proper training, and that the Nursing and Midwifery Council and the GMC should urgently review their approach to training on sickle cell conditions. Again, I don't think I've seen a response from the NMC or the GMC to this. That may be, I may be mistaken there. But unless people are properly trained in this, how are they going to make difference in future? The fourth issue, I think, is the issue of race and racism and discrimination within the NHS. I know from my own constituency, representing a very diverse community, and the work that I've done with Leicester Against Racism, that there is much that can be done to improve understanding of the different issues facing BME communities within the NHS, to improve access to and outcomes of care, to understand the implicit and explicit discriminatory attitudes that may be present in the NHS, and to crucially, to have better representation of BAME communities in senior NHS leadership positions. You know, look at the debate today that we've had with people talking about their own experiences, understanding the issues, showing that Parliament can act on the issues that matter to our communities because of our diverse representation, and that's what we need in the NHS. I hope the Minister will be able to say what NHS England is doing about these issues. Last, but absolutely by no means least, because the NHS always changes its structures, its organisations, because people move around, I think it is often difficult to embed change within the system. And in my experience, the only way to really do that is to give patients and their families far more voice. I include training in that. I mean, imagine if my honourable friend, the member for Vauxhall, if she wasn't extremely busy representing her constituents, was involved in the training of all health professionals, told your story, people could hear what had happened to you. I think that would be a powerful driver of change if the people who use services can be part of the training of the way the system is regulated. That is how I believe we get real change in the system. And I hope that the Minister will set that out too. In conclusion, this report provides an opportunity to make substantial and lasting change. I hope the Minister will set out the government's response when she stands to speak. Thank you.
Minister.
Thank you, Ms Miller. It's a pleasure to serve under your chairmanship. And can I start by thanking the Right Honourable Gentleman for Wolverhampton South East for securing this important debate and for all his hard work chairing the All-Party Parliamentary Group and for the report he has put together, because it is a crucial report that highlights some of the gaps in the treatment, the management, the experience of those with sickle cell. And can I also thank the Honourable lady from Vauxhall for sharing her experience with us, because I think hearing the first-hand experience of what it is like to have a family member going through a sickle cell crisis and the experience of healthcare is extremely helpful, and I thank her for sharing that with us today. Because it is right. I think anyone who's read the No One's Listening report cannot fail to be moved by some of the findings there, and that it's such an important issue when we consider that the majority of patients who suffer with sickle cell are in fact black, and the tragic death of Evan, highlights some of those disparities that are part of the issue. This is much more than a physical problem in terms of managing it. So I thank the APPG and the Sickle Cell Society for the work they've done to shine a light on the challenges facing sickle cell patients. And any failure in care is one failure too many. And I want to reassure all of those today on all sides of this chamber that the government is not just listening, action is taking place right now, and there have been some changes already since the report was done that I think colleagues will be very pleased about, that we want to build on. But I'm clear that where the gaps remain, I'm very happy to work with the APPG and members across the House to address those gaps that have been highlighted in the report. Because and I think, as the Shadow Minister said, working with the sickle cell community is vital if we're going to address many of these issues. And NHS England is doing that. And they've worked with the community in developing a new service. And the specifications have outlined a new model of care with the development of 10 hemoglobinopathy coordinating centres, or HCCs, for sickle cell disease care in England, each leading a network of care and overseeing specialist teams and local centres. And what this means is what many have described in this debate today, is that these specialist centres, which is where patients experience really good care, feel very confident, get great advice, are able now to reach out to local centres to be able to share their experience. So if a patient doesn't have access to a specialist centre, they can still access that specialist care through their local facilities. And this is only just starting off, but it's making a huge difference, both in the experience of patients, but also supporting staff, many of whom may have never encountered a sickle cell patient before. Some may have, but it may have been a long time ago. And having that support of specialist input is absolutely crucial. And in addition to this, the National Hemoglobinopathy Panel, it has been set up to run a national multidisciplinary meeting and provide clinical leadership and coordination for these HCCs, so that that patients' cases can be reviewed by a national group of specialists and recommendations and support fed in. NHS England have also provided funding during the last year and for this year as well to develop and update a national register, a database of UK patients with red cell disorders. So what hasn't happened before, although testing's been available for babies to identify if they have sickle cell, that's never been fed into the NHS before. And so with this new register, GPs, hospitals can all identify who in their local communities has sickle cell and can start to plan resources and services accordingly. And so that hopefully no one is missed through the gaps. And so when a patient turns up at A&E, they are identified as a sickle cell patient without them having to go and explain all the issues they're facing. Of course.
Jenna Dolby.
So much for what you're saying in terms of the list that will be created for babies and so on. Will there be a similar list in terms of the professionals within certain areas that have experience with working with sickle cell patients? Obviously, you're saying that this will be set up retrospectively, but it'd be good to know what resources is already available in certain areas.
Yeah, I think she makes an excellent point, and that these HCCs, so these specialist networks that have been set up, so the 10 of them around the country, will do just that, and they will be registered, so anyone who's got a sickle cell community and there's not specialist provision available can feed into that and advice be given back and forth. So it's the start of the process of making that happen in practice. And there hasn't been an evaluation yet because it's very new, but it's expected that when it does publish its results of its activity, that a significant improvement in standards will be seen, and the results will be used to target areas of concern. So we'll see where improvements have been made and improvements still need to be made. So I think once they start to report back, I think colleagues will be very pleased with the progress that's being made. Now, education and awareness of medical professionals, I think, was raised by everyone in the debate and was highlighted in the No One's Listening report. Health Education England has made recent improvements to the medical curriculum in relation to both sickle cell and thalassaemia. And now in the curriculum, as core competencies, that there are modules on this. And Health Education England has held discussions with Royal Colleges to ensure the curriculum is delivered to all 4 nations as well. There are now 2 e-learning modules with sickle cell content, NHS screening programmes and the maternity support worker programme, and other e-learning programmes on wider areas are also now including sessions on sickle cell, included in anaesthesia, radiology and pain management. So I think we are making some progress on that. But for me, as someone who's worked in healthcare, I think that education needs to be ongoing. It's great to get some education when you're a student, but if you don't come across a sickle cell patient for 5 or 6 years, that learning may be at the back of your mind. So ongoing education, I think, is something we also need to focus on. In terms of blood and transplant, NHS Blood and Transplant have been are working really hard to improve the service experience by patients. And given that up until recently blood transfusions were only one of 2 treatments for the conditions, much work has been done on this. And they submitted, I believe, evidence to the report and described a number of areas that they're involved in that could be improved. And some of this is being worked on right now, including improving matching of more donors of African descent, improving coordination of care, and improving consistent access to red cell exchange services. So, again, some work is being done on that area specifically. Now, as has been mentioned by many colleagues, we know sickle cell disease is particularly common in people with African or Caribbean family backgrounds, and addressing health inequalities, which are made much worse if you've got sickle cell, or in fact if you've experienced COVID, or we know in maternity that women from Black and Asian ethnic groups are disproportionately having negative outcomes. I'm meeting with the Equalities Minister fairly soon to look at the specific areas of health where particularly Black communities are disproportionately affected and have poorer outcomes. And so I'm very happy to update colleagues. We're very keen to look at those areas and work jointly with myself and the Equalities Minister to try and improve outcomes in those areas. But the Office for Health Improvement and Disparities, launched in October this year, plans to tackle health disparities across the UK. Also, the NHS Race and Health Observatory has developed a new evidence-focused remit to tackle ethnic health inequalities, and sickle cell is one of those areas that the observatory is looking at. And coinciding with this report launch in November, the observatory appointed a sickle cell expert, Dr. Carl Reynolds, to drive forward work in this area. And Dr. Reynolds is reviewing the evidence that contrasts sickle cell care with other rare genetic diseases and to examine how robust sickle cell care patient pathways are within the NHS. And this work will additionally support the work of other organisations, and I think will build on much of what was found in the report. Now, I just want to just touch on research and treatment. I think, as the Right Honourable Gentleman said, there is a new drug that's been developed and was recommended by NICE for sickle cell disease, the first in over 20 years. And it's expected to reduce the number of times a patient will end up in A&E and go through a crisis. But research is vital to develop new drugs and to improve treatments. And I want to reassure colleagues that funding is available. The National Institute of Health Research has £1 billion a year set aside for research. Any condition can apply for funding from that pot. It's often the case that rare diseases such as sickle cell are not coming forward with proposals because sometimes better known conditions have much more researchers, clinicians, charities driving them forward to apply for research funding. So there is not just funding available, but help and guidance. If there's research that clinicians, academics want to do in this area, we're very much keen to see them come forward and apply for that funding. If they're not successful, provide feedback as to why that was. So funding is available. It's not ring-fenced for any particular condition, and all conditions can apply. So in conclusion, I just want to thank all members of the All-Party Parliamentary Group, again, for their hard work on behalf of the sickle cell community, but also for the report. I think it is a really important report. It highlights much of the discrepancies, the gaps that sickle cell patients have been facing, because it isn't acceptable that someone like Evan died simply because there wasn't the care and expertise that when he was admitted to hospital, and we want to change that. And I think what the debate we've heard today really highlights how much work there is to do. I will give way.
Bill Rubira-Addy.
Concludes, there's one point I don't believe she has touched on, and that's the issue of prescriptions. I would be grateful if she could let us know if there are any plans that the government has to make prescriptions free for people who require medication for sickle cell.
Minister.
Yeah, absolutely. She does make a good point, because most patients are probably young, of working age, and have to pay for their prescriptions. But around 89% of all community prescriptions are not paid for, are free at the moment. And for those with long-term conditions such as sickle cell, there is the prepayment certificates where for around £2 a week, no matter how many items they have to order, are covered by that certificate. And say someone's on 3 items, that's around about a saving of £228 a year. So I know that doesn't give free prescriptions, but that is a system that's in place that often patients aren't told about, that can make a huge saving to their income. And I'm happy to discuss that with the Honourable Lady after this debate. But I want to reassure colleagues that a huge amount is being done by the department to improve the treatment of sickle cell patients. And there is clear and positive work that's underway that's quite new and innovative, that we hopefully will see a difference in a very short space of time. There are still gaps in the provision of services.
Kate Osmond.
Thank you for giving way. Thank you for the update you've just given us. You haven't said anything about A&E, and that is where there is a bottleneck of issues where, you know, patients arrive and they're not being listened to and not being believed. What work is the government going to be doing on that area in hospital treatment?
Yeah, she makes an excellent point. And there are nice guidelines on sickle cell, and I'm very interested to look, and I will look and ask department colleagues to look at how often they're not followed. So there was raised the issue of analgesia being given within half an hour of someone presenting. That is within nice guidelines, and it should be being what's followed in A&E or other areas where patients are admitted to. So I'm very happy to look at the prevalence of that not happening and why not. And again, I think a lot of it is not deliberate. I think much of it is around education of staff who maybe are in busy A&E departments, have lots of people in pain, and maybe not realise the impact for a sickle cell patient in getting that analgesia in a timely manner.
I'm very grateful to my honourable friend. On this point of A&E, and I welcome, as I'm sure colleagues do, the commitment to look at the figures. But given that we have reports in the APPG's report, could the Honourable Lady perhaps circulate through the NHS to A&E departments just to remind them of the current NICE guidance?
Yeah, my right honourable friend makes an excellent point. I'm very happy to work with department officials to look at how we can, if the NICE guidelines are there, how we can make sure that they're distributed so all clinical areas are aware of them. Particularly, I think the point was made, areas where there's a high prevalence of sickle cell and are more likely to see someone admitted to A&E. So I'm very happy to take that forward. But I just want to reassure colleagues that while progress is being made, and I'm very pleased and I want to place on record my thanks to all those in specialist units that are working really hard behind the scenes to improve the care for sickle cell patients and to get that information out across the board of the NHS. Where there are gaps that exist, I'm very happy to work with the APPG to make sure we address those.
McFadden to wind up.
Thank you, Ms Miller. I'd like to thank everybody who's spoken and contributed to the debate this afternoon. It may be unfair to pick people out, but I just want to pick out my honourable friend for Streatham, who gave us evidence as a witness to the inquiry when we were taking evidence, and my honourable friend, the member for Vauxhall, who spoke so movingly and powerfully today about her mum, and to reflect my honourable friend for Streatham's words that I know that her mum would be really, really proud of her today and what she said in this debate. I'm grateful to the Minister for the response that she's given today, for the spirit in which she's listened to the debate, and responded. And it's good to hear about things like the specialist units, the expert who's been appointed, and the other things that she has highlighted. It's good to hear about all of that. But the test of this will be in the lived experience of sickle cell patients themselves. And one of the problems that's been highlighted in the debate is that often the protocols are there, the 30-minute guidance is there, the care plans agreed with individual patients are there, but in the day-to-day experience they're not being adhered to. Right. And so part of this battle is to make sure that things that are already there are actually applied properly, and anything she and the department can do to reinforce that is welcome. And I just make this final appeal to the Minister to make this report a moment for change, not just a debate that's here today and that's gone tomorrow. So I appeal to her to go back to the department, to gather the officials, call in those different key parts of the NHS and tell them, this time we are going to listen, this time we are going to make a difference, and this time we're going to change things for good for people in this country living with sickle cell. Thank you.
The question is that this House has considered the treatment of sickle cell. As many as are of that opinion say aye. Of the contrary, no. I think the ayes have it. The ayes have it. Order, order.